Dr. Harshavardhini Patel, Emergency and Critical Care Physician. Today, I'm here to talk about the very basic concepts of fluid responsiveness. As we all know, circulatory shock is one of the important clinical presentations which we encounter in day-to-day clinical practice, being in emergency or in critical care. The main goal in circulatory shock is volume expansion. Fluids and vasopressors are the drugs of choice here. But whether to start fluids alone, whether to start fluids along with vasopressors, or whether to start vasopressors is a very critical therapeutic dilemma we all face. There's a lot of unanswered questions when it comes to fluid resuscitation. When can we give fluid? What type of fluid? How do we give it? In whom do we give it? A lot of unanswered questions. There's a lot of inconsistency and unpredictability as well. So, in my talk, I'm going to discuss the basic physiological principles of fluid responsiveness. As you can see, let's start with understanding how do we estimate the cardiac output. The cardiac output is directly related to our stroke volume and heart rate. The delivery of oxygen at the tissue level is determined by the arterial oxygen content and our cardiac output. So, this is Sir Otto Franklin and this is Sir Ernst Sterling. So, what did Sir Otto Franklin tell us? He told us if we can stretch the ventricles prior to the cardiac contraction, there will be increased force of contraction. Sir Ernst Sterling told us we can keep the ventricles stretched prior to the cardiac contraction simply by increasing the venous return. So, increased venous return will bring about increase in the stroke volume. They proposed a curve which is known as the Frank-Starling curve. This is the basic foundation on which the whole dynamics of fluid resuscitation is built on. As you can see in the steep upper portion, in the steep portion of this curve, if you give the patient fluid challenge, there will be increase in the cardiac stroke volume from this point to this point. As you go higher upwards, increase in the preload will not exactly translate into increased stroke volume. So this is the cardiac output curve. Then we have the same curve, which is the cardiac function curve. In this cardiac function curve, you have three. One is the one with the normal cardiac function, increased cardiac function, and your reduced cardiac function. To begin with, the x-axis is the right atrial pressure, the y-axis is the cardiac output. Increasing the right atrial pressure, if the cardiac function is normal, will increase your cardiac output to a certain extent in the steeper portion of the curve. Whereas, if the cardiac function is weak, increasing the right atrial pressure actually does not translate into increasing your cardiac output. As you can see, this remains same. The cardiac output remains same. So what is preload exactly? Preload, most of the blood in our body is concentrated in the capacitance vessels. These capacitance vessels have some amount of volume already to keep them patent. That is called your unstressed volume. Over and above this is your stressed volume. This is the one which will be reaching your heart, or this acts as the active component of your venous return to the heart. The mean systemic filling pressure is nothing but the driving force for your venous return. As you can see in this, increasing the stress volume, we increase the mean systemic filling pressure, and there is a component of venous resistance here, which will ultimately determine your right atrial venous return or your preload. So you have unstressed volume, stressed volume, and mean systemic filling pressure. Finally, putting it all together, venous return is determined by mean systemic filling pressure minus the right atrial pressure, and it is inversely related to the resistance of your venous circuit. So, how can we increase the venous return? If you see in the equation, if we reduce, what happens if we reduce the right atrial pressure? As we go on reducing the right atrial pressure beyond a critical limit, your right atrium will collapse, which in turn will increase your resistance against which your venous return has to reach. So that is not possible. What if I reduce the resistance in the venous circuit? If I go on reducing the resistance in the venous circuit, as I told you, it is the capacitance vessels. There will be increased compliance. This increased compliance will in turn cause increased accumulation of unstressed volume. You need some volume to keep it patent. So the more compliant it becomes, you need more unstressed volume to keep it patent. This doesn't effectively contribute to your venous return. Finally, the only way left is by increasing my mean systemic filling pressure. How can I increase my mean systemic filling pressure? This could be either by giving fluids or by doing by venoconstriction, that is with our vasoconstrictor agents. So if you can see here, right atrial pressure, if I go on decreasing beyond a critical limit, there is no venous return which can happen because there's increased resistance to it. If I increase my mean systemic filling pressure from here to here, there is obviously increase in my venous return. If I reduce my systemic venous resistance from here, it will bring down my venous return because most of the volume is going to become our unstressed volume. So when all of the studies were taking place, the initial thought process was whatever is given to the heart comes out of the heart, meaning all your preload is converted into your cardiac output. Then we had Dr. Guyton, who told us he superimposed our cardiac function curve, which is 3 curves, onto a venous return curve, which is 2 curves. And he interpreted that the both venous return and cardiac output is function of our preload. And he brought out the concept called transmural pressures. That is the difference between the extracardiac and the intracardiac pressures. Okay. So finally, if you look at this curve carefully, the point 1, this point is, this is same. The x-axis is the right atrial pressure. The y-axis is your cardiac output or venous return curve. As I told you, both are function of preload. When the cardiac functions are low or decreased, if I start increasing the right atrial pressure and if I start increasing the mean systemic filling pressure, this is your baseline mean systemic filling pressure. Once I start increasing your mean systemic filling pressure with the poor cardiac function, the difference between the cardiac output at point 1 and point 2 is nil. By increasing the mean systemic filling pressure with a poor cardiac function, I'm not actually able to gain anything. So absolutely there is no increase in the cardiac output. It only simply is increasing your right atrial pressure. The same thing when I do at the point 3, that is in a normal functioning heart, if I increase your mean systemic filling pressure from this small dotted lines to the broad dotted line, you can see there is effective increase in your cardiac output. And also there is effective increase in your venous return. So increase in your venous return by increasing the mean systemic filling pressure is translating into increased cardiac output. Finally, point 4 is nothing but the point of critical pressure, beyond which if the right atrial pressure crosses this critical pressure, there's effectively no increase in the cardiac output because there is no absolute venous return happening to the heart. Okay. So, how do we know whether the patient is fluid responsive or not after understanding all this physiology? We have clinical measures. There are 2 types of clinical measures. One is the static indices and one is the dynamic indices. Static indices simply means here we use variables which indicate the momentary heart preload. The example of static indices is your blood pressure, your CVP. All these are indirect measures. Your pulmonary artery pressures, All of this is at one point of time we are measuring. So it might not effectively tell me whether the patient is preload responsive or not responsive. Dynamic is provoking the circulation by inducing changes in the loading conditions of the heart. So we uncover the heart-lung interactions here. What are your dynamic indices? I will talk about it in some time. Coming to heart-lung interaction. Phasic changes in the respiration changes the thoracic pressures. This is a very well-known fact. This changes in the thoracic pressure is transmitted to the heart as well. As I told you, there is some concept of transmural pressures. So, this heart-lung interaction has influence on our venous return, the preload as well as our afterload. There's some concept called ventricular interdependence. We have our right heart, we have our left heart. Both of us is divided by a thin ventricular septum. Increasing the right ventricular pressure causes the septum to bulge onto your left side, thereby decreasing the LV cavity volume and thereby decreasing your LV output or your cardiac output. That is the concept of ventricular interdependence. And finally, not necessarily the changes in the right heart gets translated into the left heart immediately. There is something called a delay because of the pulmonary transit. After 2 to 3 beats, the changes in the right heart will reflect onto the changes in your left heart. Most of the heart-lung interactions, the heart-lung interaction happens in both the times, the spontaneous respiration as well as when patient is on positive pressure ventilation. So coming to when patient is on positive pressure ventilation, this red graph over here is your positive pressure ventilation. So during inspiration, there is increase in your pleural pressure and increase in your transpulmonary pressure. Increase in your pleural pressure decreases your RV preload, increases your RV afterload. There is effectively decrease in your RV stroke volume. Whereas increase in your transpulmonary pressure along with increased pleural pressure will decrease your LV afterload and increase your LV preload. This effectively causes increase in your stroke volume. So once you put a patient on mechanical ventilator, if the patient is hypovolemic, to begin with, the patient might maintain the blood pressure for about 2 to 3 beats initially. So the pulse pressure variation may be maximum at the end of inspiration. After the pulmonary transit time, after about 2 to 3 beats, the decrease in the RV stroke volume which happened due to increase in the pleural and transpulmonary pressures will finally reflect on the left side by decreasing your LV preload, decreasing your LV stroke volume and thereby decreasing your cardiac output. So we have a heart and then we have a thoracic cavity. So if the patient is on mechanical ventilator, the positive pressure will decrease your RV preload and increase your RV afterload. Effectively, there is very little change in the LV immediately because this pressure changes, positive pressure changes are technically increasing your LV preload by squeezing out all your pulmonary vasculature blood into your LV. And there is decreased LV afterload. So there is increased stroke volume. Okay. So the same things. How do we assess this? The ways to assess this is either when the patient is on mechanical ventilator, there are few prerequisites. Your patient should not have spontaneous breath, should not have any arrhythmias, and the compliance of the lung should be normal. Under this ideal situation, you can use tidal volume challenge, end expiratory occlusion, or you can mini fluid challenge and PLR test. Most of your dynamic indices need this prerequisite, but whatever I told now can happen when your patient is having spontaneous breath, when there is arrhythmia or poor compliance of the lung also. Otherwise, for measuring dynamic indices, you need to have the prerequisites like what I told you. When we give a fluid challenge, if the patient's cardiac function is good, if the patient is fluid responsive, this will translate into improved cardiac output. Whereas, as you can see from normal, as you come down, the cardiac output changes also decreases to poor ventricular compliance or poor ventricular systolic function. Okay. So this is PLR. How do we go about doing PLR? This can be done in patients, as I told you, who are spontaneously breathing, who are not on mechanical ventilator or on mechanical ventilator with spontaneous breath, arrhythmias or poor compliance of the lung. So all of this will need a real-time cardiac output monitor. Now, we have a surrogate which can be used by using echocardiography. That is, we can monitor cardiac output by measuring other surrogate markers as well. I'm just going to discuss to you about the basic maneuver of passive leg raise test. Okay, so to begin with, you have to measure the cardiac output while the patient is at 45-degree recumbent position. Step 2 is this should be automatically operated bed where the position changes to the leg is raised to about more than 45-degree, and this position to be maintained for about a minute. You measure the cardiac output at this position using the bed adjustment. Okay. Finally, you bring the patient to the position 1 again, and again you check for the cardiac output. You will use various indices while doing this maneuver. You can use VTI, you can use your cardiac output monitor, pulse pressure variation or stroke volume variation along with the PLR to know your fluid responsiveness. So as I told you, the various indices what we can use, dynamic indices are pulse pressure variation or stroke volume variation. Most of the monitors, advanced monitors are having this inbuilt. You have to just choose the module for it. And then using echo, we can use velocity time integral. And finally, IVC can also be used. IVC can act both as a static indicator as well as a dynamic indicator. If we are just measuring the collapsibility of IVC, then it is a static indicator. If we are using the if we are just using 50% collapsible or dilated or constricted IVC, it's a static indicator at one point. When the same thing you see it with respiratory variation as distensibility index or collapsibility index, then it is a dynamic indicator. Thank you.